I'm Dr. Reginald Gohh. I'm a transplant nephrologist with the MedStar Georgetown Transplant Institute. I primarily see patients who are in need of a kidney transplant. I do their evaluations and I see transplant patients after transplanted through the course of their lifetimes. My philosophy of care is an interactive approach with the patient along with other members of the staff. I think it's important that transplantation is really a team effort, including the patient as well. The most rewarding aspect of the work that I do is that I see patients through the spectrum of their lives. I see them from the pre-transplant period, and they get transplanted and they go on to successful careers and lives. I've been to people's weddings, I've been to their graduations, and I've been with them through their journey with their own children. The future of transplant nephrology is very interesting. There's this prospect of having organs obtained from xenotransplants, meaning pig transplants. I think that prospect will probably be about 10, 15 years away, but there is that true possibility that may occur. I'm primarily driven to patient care. I like looking forward to seeing my patients in clinic. I like looking forward to seeing patients in the hospital after freshly transplanted. Fresh kidney transplants are like delivering a baby. Everybody's happy because the kidney's working well, and generally the outcomes are fantastic. I think this program has the clinical quota to reach excellent proportions. I think this could be the best kidney transplant program in the country. We have the right people, I think the right interests, the right tenacity to move forward with it. I think the support from hospital administration is particularly strong in this program. I think we can be number one. A transplant nephrologist is responsible for the patient care from the initiation evaluation to successful transplant outcomes. So that includes getting them prepared for the transplantation through their evaluation process and following their transplant, managing their immunosuppression and possible complications thereafter. By far the most common cause of kidney disease is diabetes. And part of our journey should be to prevent kidney disease from diabetes, amongst other things as well. So part of our responsibility as nephrologists is to sustain the function of a person's kidneys before they need a transplant. And that's, I think, part of the education process that we should be providing for the patients and outside physicians as well. Family history and smoking clearly play a role in the risk of developing kidney disease. Not everybody who smokes develops kidney disease, but obviously you try to mitigate any factors that can promote the progression of kidney disease. When I deal with a patient with end-stage kidney disease, I tell them from the start, first of all, you've been dealt a bad blow, and you have kidney failure, and you have two options available to you. You have either doing dialysis, which is usually two forms, either peritoneal dialysis, where fluid is instilled into the abdominal cavity and draws out the impurities, and then you drain the fluid out. That's a continuous process. There's also hemodialysis, where your blood is filtered of impurities over a certain period of time. And finally, the best option of all is kidney transplantation for those who are deemed healthy enough to pursue this type of treatment. When a patient gets referred to us for a kidney transplantation, they have to go through this evaluation process. And that includes a series of tests and exams to make sure that they're healthy enough to undergo kidney transplantation. One of the most important things when we evaluate a kidney transplant patient is, do they have a living donor? A living donor provides improved outcomes compared to a deceased donor kidney transplant, and that's one point that should be emphasized. Once they're put through the evaluation process and they're deemed acceptable candidates, we put them on our kidney transplant list. But preferably, we aim to get a living donor kidney transplant done first. When a someone has end-stage kidney disease, people often ask me, or the patients often ask me, how long am I going to live? And that is not necessarily an answerable question, but on average, about 20% of patients with kidney failure die within the first 5 years. So my approach to the patient is, so you want to improve your chances as best as possible. So without a doubt, kidney transplantation offers a survival advantage compared to staying on dialysis. On average, a deceased donor kidney transplant lasts about 11 years. A living donor kidney transplant lasts about 20 years. You know, if the first one fails and they go through the reevaluation process and they're still deemed healthy enough, then we can pursue second, third transplants. I've had children who had their first kidney transplant at age 5 are now going through their 4th kidney transplant. So this is clearly the best option for the patient. Now, having said that, there are some patients who are so sick that kidney transplantation is just not a viable option for them. Patients often ask me if they'll have any restrictions following a kidney transplant. For the most part, they should go on living as normal lives as possible. They should be able to return to work if they feel functional enough. There are some common sense issues. There's an increased risk of infection following kidney transplant, and obviously they shouldn't put themselves at risk for such events happening. I think if patients are referred to me for either kidney or pancreas transplant evaluation, the first part of the process is accepting the fact that they have these problems, and you say to yourself, what can I do best for myself to improve my outcomes? And once people come to that realization, then the journey towards kidney or pancreas transplantation begins. When patients have an excellent kidney transplant outcome, this is really a collaborative approach between the patient and ourselves. I tell patients, if you want to have a successful outcome, you have to follow directions, you have to take your medications, and you have to go through your follow-up appointments. You have to come to me if there are issues or questions, and I'll be there 24/7 to help you answer that. I think as a group, I think this successful outcomes not only include the patients, the physicians, the nurses. It's really a team approach amongst everybody. So my early research focused on the pharmacokinetics of kidney transplant anti-rejection medications. So why did I go into this? Because kidney transplantation is a crude science. Our first deliverable is to provide a kidney transplant to a patient. Our second deliverable is to give them immunosuppressive medications. About 85% of these patients will do perfectly fine. 15% of them will reject. Another certain amount will develop malignancies and infections. So you ask yourself, why do certain people do well and why do others have problems with their medications? So perhaps it has to do with how these drugs are delivered to them, how they absorb the drugs, and how they handle these drugs. And that started my foray into pharmacokinetic therapy. I have been involved in over 100 research trials in the last 25 years. Many of these trials have included the use of novel immunosuppressive drugs. And I've generally been through with these trials from the very beginning, including pharmacokinetics of these drugs, and seen how they work. So actually I have a pretty distinct understanding of where we are now with the drugs available to us. Xenotransplants are organs from different species, such as different animals. So genetic barriers to us accepting a xenotransplant, for example, a pig, has been the genetic differences between us and the high risk of rejection amongst those organs. Through bioengineering, the possibility of us being able to accept those organs, particularly in a continuous fashion, is becoming closer to reality. I wish patients would ask me how they can help in the journey of their transplant progress. I think they should be as vested in their own outcomes as we are. I always tell my patients, let me worry about things, and I'll let you know when you need to worry. However, I do think that they should also be as interested as I am in how things will turn out in the end. My philosophy of care in dealing with the kidney transplant recipient is that this should be a collaborative approach with the patient and ourselves. I believe in the whole team effort. This does not just include the physicians, it includes the nurses, the pharmacists, the surgeons, and the patient themselves. So why should a patient choose to come to MedStar at Georgetown? So to preface that, I would say there are excellent transplant programs around this area. But if you look at the volume of growth that this program has gone through in the last few years, it's astronomical. And I think the component that is poised to grow is the amount of research, the amount of collaboration that we can do amongst ourselves. And I think, we try and set up a superstar team to take care of the group of patients that we have. So I think there's excitement as to what we can achieve in the next few years, really.